The liver is an essential organ responsible for conducting a myriad of bodily functions. It is a very diligent organ, able to function under harsh conditions. Hepatocytes are highly regenerative, with the liver being able to regrow up to 70% of its total mass. However, if the liver undergoes a repetitive barrage of injury, devastating structural changes will occur. Excessive alcohol consumption leads to hepatic inflammation and subsequent necrosis. When the liver is frequently subjected to alcohol exposure, irreversible fibrotic scarring occurs known as hepatic cirrhosis. Cirrhosis remains the 8th leading cause of death in the United States, and demographic data suggests a higher prevalence in men. This case scenario will follow Mr. Michael Smith, a 49-year-old African-American male with alcoholic cirrhosis. His comorbidities include chronic alcoholism, hyperlipidemia, and gastroesophageal reflux disease. Mr. Smith has prescriptions for Lipitor, 20 milligrams by mouth every night, ranitidine, 75 milligrams by mouth twice a day as needed, and propranolol, 50 milligrams by mouth twice daily. Mr. Smith is aware of the detrimental effects drinking has had on his liver and his life, as it severely impacted his relationship with his only daughter, Elizabeth. However, this has not stopped him from consuming alcohol. Let's take a closer look at what Mr. Smith is up to.
I'll have another.
You have too much. It's a lot of things. Sorry.
Today is Mr. Smith's birthday. Normally this would be a time of celebration, but for Mr. Smith, we find him all by himself, consuming alcohol in excess. Something's got to give with Mr. Smith's lifestyle choices, or he might not be around to experience his next birthday. Come on, Elizabeth, pick up, girl.
Not available. Please leave a message after the tone.
Hey, Lizzie girl, it's your father. I'm calling again just to let you know it's my birthday today. You know, I miss you, and I'll speak to you soon. Okay. All right. I love you. Talk to you soon. Bye. Michael, get it together. One more drink. One more. That's all I need. One more. Celebration, ain't it?
It appears that Mr. Smith's daughter Elizabeth wants nothing to do with him, despite her upcoming wedding, which he was never informed of. The thought of not being involved in one of the most important days of his daughter's life has invoked an urge within Mr. Smith to set things straight. Mr. Smith calls his primary physician and schedules an appointment to evaluate the extent of harm alcohol has imposed on his well-being. Here we find Mr. Smith meeting with his primary care physician, Dr. McCoy, and explaining to her how he's had enough and he's ready to change.
Like I previously mentioned before, Mr. Smith, you have to stop drinking.
Listen. I'm gonna stop this time. I've hit rock bottom, okay? This is it. I'm gonna stop.
I feel like we've had this conversation a lot before. What makes this time any different?
It's my daughter. She doesn't want me to be a part of her life. She's getting married this summer, and my little girl doesn't want to be walked down the aisle by her father. And I don't think I could live with myself if she's not a part of my life.
Well, I'm sorry to hear that, but you still have to prove to me that you're serious. You need to attend your AA meetings and meet with your sponsor.
Yeah, I'm gonna do everything. I'm gonna stop drinking. I just want to get on track, but I know things, just the way I feel in the mornings and just the marks on my body, I know that things aren't going right with my liver, so I have to see it.
Well, let's run some tests. Let's check your liver function test and see how bad your liver is. But most likely, we're gonna need a TIPS procedure.
Surgery?
Yes.
All right, whatever it takes.
It's good to see you.
Dr. McCoy goes on to order a set of labs and tests to evaluate the progression of Mr. Smith's cirrhosis and to rule out any contraindications towards Mr. Smith having a TIPS procedure done. Acute liver failure, sepsis, encephalopathy, and an INR greater than 5 and platelets less than 20,000 are a few contraindications that can be determined by blood work. CAT scans, transthoracic echocardiograms, and cardiac catheterizations will be ordered to rule out isolated varices, splanchnic vein occlusion, biliary dilation, cavernous portal vein, heart failure, and pulmonary hypertension. After obtaining Mr. Smith's labs and imaging, it suggests that he could benefit from a TIPS procedure for the indication of refractory ascites. Mr. Smith has already received 3 paracentesis procedures over the last 2 years, which were minimally effective. Therefore, since this intervention appears to be insufficient, Dr. McCoy schedules Mr. Smith for a TIPS procedure. From here, Mr. Smith's next course of action is a pre-surgical workup to evaluate coexisting conditions. This will include evaluating cardiac function related to hyperdynamic circulation, ruling out heart failure, and checking for severe pulmonary hypertension, which would be a mean pulmonary artery pressure greater than 45. Evaluating respiratory function to rule out the presence of intrathoracic fluid collections, and grade the patient's level of decreased functional residual capacity. This also includes checking for the presence of coagulopathies, checking for the presence of renal dysfunction, and checking for the presence of ammonia, as this procedure will make it worse since the shunt bypasses the liver. On the day of surgery, Mr. Smith arrives to the hospital, nervous but excited to take the next step towards changing his life. Mr. Smith is introduced to his CRNA, Oliver, and Oliver performs a preoperative assessment. Mr. Smith's assessment includes a patient interview where Oliver will ask about past surgeries, a family anesthesia history, whether he experienced a sore throat from previous intubations, required smaller breathing tubes, or experienced damage to his teeth with prior intubation attempts. Next, Oliver will perform a focused exam on the airway, lungs, and heart. The airway exam puts precedence on the interincisor distance, upper lip bite test, sternal hyoid distance, thyroid mental distance, and Mallampati score. Assessment of the lungs includes basic auscultation of both anterior and posterior lobes, as well as monitoring the pulse oximetry for any presence of desaturation. With Mr. Smith having cirrhosis and ascites, it's important for Oliver to determine the degree of pulmonary compromise when Mr. Smith lays flat or stands up, which is checking for the presence of platypnea or orthodeoxia. Assessing the heart includes checking the heart rate and blood pressure, as patients with cirrhosis have splanchnic vasodilation, which can make them hyperdynamic. After the focused assessment, Oliver should find out the severity of Mr. Smith's liver disease by calculating Child-Pugh and MELD scores. The Child-Pugh classification system looks at albumin, bilirubin, PTINR, ascites, and encephalopathy to determine the patient's ability to tolerate a procedure. Patients that have a Child-Pugh Class C should not undergo elective surgery. Mr. Smith's albumin is 3.6, which is 1 point. His bilirubin is 1.8, which is another point. His INR is 1.7, which is 2 points, and his ascites is refractory, which is 3 points. He is not encephalopathic. This places Mr. Smith at a Child-Pugh Class B, which indicates an average prognosis. The model for end-stage liver disease, or MELD score, is another evaluative study used to determine the severity of cirrhosis. This score is also used to predict the patient's likelihood to survive surgery and for the purpose of transplant eligibility. Mr. Smith's creatinine is 1.1, his bilirubin is 1.8, and his INR is 1.7. Mr. Smith's calculated MELD score is 16, which indicates he has a 15% TIPS mortality risk. The final step that the CRNA Oliver should perform is reevaluating Mr. Smith's preoperative labs and tests. This will ensure that Mr. Smith's condition is optimized for surgery. This includes looking at the albumin, bilirubin, PTINR, creatinine, LFTs like alanine aminotransferase, aspartate aminotransferase, alkaline phosphatase, and gamma-glutamyl transpeptidase. Additionally, a CBC should be drawn primarily to focus on platelets. A BMP should be drawn primarily to focus on sodium, potassium, and serum glucose. And a blood type and screen should be drawn just in case Mr. Smith requires any blood transfusions intraoperatively. Oliver should also look through Mr. Smith's ECG, echocardiogram, and any prior X-rays or CAT scans. Using the information obtained from the preoperative assessment, Oliver was able to determine that Mr. Smith is an ASA Class 3. Mr. Smith received a unit of platelets for a platelet count of 24, and phenetadione, synthetic vitamin K, for an elevated INR of 1.7. Mr. Smith's height of 6'3" and weight of 90 kilograms were obtained as well. An allowable blood loss estimate of 2,025 mLs was determined utilizing Mr. Smith's hemoglobin level of 10 and hematocrit level of 30. After Oliver completes the preoperative assessment, he informs Mr. Smith of the anesthesia plan, which includes the procedure being performed under general anesthesia. Mr. Smith's anesthesia plan will include a rapid sequence intubation related to the high likelihood of gastroparesis and his ascites. He will be induced with propofol, and paralyzed will be provided with cisatracurium, and analgesia and sedation will be provided with remifentanil and propofol infusions. In order to keep a close surveillance on Mr. Smith's blood pressure, he will receive an invasive hemodynamic monitor known as an arterial line. An A-line serves two purposes during this procedure, and therefore should be hooked up with a double pressure transducer. This will allow Oliver to visualize Mr. Smith's blood pressure, and the second transducer will display the venous pressures that will be analyzed by the radiologist at different points during this procedure. Mr. Smith will receive two peripheral IV catheters, as well as periodic blood sugar checks to rule out hypoglycemia. Mr. Smith is brought into the hybrid OR. He is then transferred onto the operating room table. Oliver places a 5-lead ECG, a non-invasive blood pressure cuff, and pulse oximeter on Mr. Smith until an arterial line can be accessed. A preoperative broad-spectrum antibiotic will be provided, and patient should be pre-oxygenated. Anesthesia delivery will start off with a rapid sequence intubation. Propofol, 1.5 milligrams per kilogram, will be used as the induction dose, and cisatracurium, 0.15 milligrams per kilogram, will be used as the paralytic. The initial dose of non-depolarizing neuromuscular blockers should be increased. Therefore, with the normal dose of cisatracurium being 0.1 milligram per kilogram, we're going to increase our dose to 0.15 milligrams per kilogram. With the onset of cisatracurium being 2 to 4 minutes, Oliver should be ready to provide manual breaths to Mr. Smith until the paralytic kicks in. Confirmation of onset can be obtained using a peripheral nerve stimulator to the orbicularis oculi muscle. The absence of twitches indicates the medication onset. Now cricoid pressure should be applied, until the airway is accessed and the endotracheal tube is in place. Sedation for Mr. Smith will be obtained using propofol at an infusion rate of 100 to 300 mics per kilogram per minute. Remifentanil will be used for analgesia at a rate of 0.05 to 2 micrograms per kilograms per minute. The duration of a TIPS procedure can vary from 1 hour to well over 3 hours long. Therefore, if subsequent doses of cisatracurium are needed to provide paralysis, they should be decreased. Mr. Smith will be placed on volume control ventilation with a tidal volume of 550, a rate of 14, FaO2 of 30%, and a PEEP of 3. Oliver is cautious with the application of positive pressure ventilation, as this can decrease preload to the right atrium. Additionally, increased peak airway pressures can decrease the cardiac output. Therefore, ventilator settings should limit the use of high tidal volumes and PEEP. The use of volatile anesthetics, especially isoflurane, is risky in patients with chronic alcoholism, as there can be a cross-tolerance between the two, which could result in the patient waking up during their procedure. Close monitoring of Mr. Smith's hemodynamics is of utmost importance due to a common phenomenon known as cirrhotic cardiomyopathy. This describes the cardiovascular variations seen in cirrhosis patients, which include increased intravascular volume of the splanchnic arteries, an elevated cardiac output, and decreased peripheral vascular resistance. Additionally, Mr. Smith could experience hemodynamic instability due to a reduced ventricular response to surgical stressors. Perioperative fluid concerns include checking for electrolyte imbalances, including sodium or potassium, and maintaining intravascular volume to ensure that adequate renal perfusion is met, indicated with a MAP greater than 65. Fluid replacement therapy should include the mindful use of isotonic crystalloids, all except lactated ringers, primarily because Mr. Smith's liver won't be able to convert the lactate into bicarbonate, which will result in the kidneys converting the lactate into lactic acid. An RSI intubation was performed due to the suspicion of Mr. Smith having elevated gastric volumes and delayed gastric emptying. So if Oliver is asked by the radiologist or surgeon to place an oral gastric tube to decompress his stomach, what should Oliver's response be? Well, despite the absence of esophageal varices on his preoperative diagnostic imaging, there's still a risk that Mr. Smith may have varices present in his distal esophagus, especially given the size of his ascites. Therefore, Oliver should not use any oral appliances such as temperature probes or oral gastric tubes to prevent the risk of variceal rupture. Mr. Smith's transjugular intrahepatic portosystemic shunt procedure will take place in a hybrid OR. This environment allows surgeons and radiologists to use real-time images for guidance during complex procedures. The TIPS procedure involves creating an intrahepatic pathway between the right and portal vein. The pathway is achieved by deploying a stent between the two vessels. This allows portal circulation to bypass the liver, which thereby reduces portal hypertension. Throughout the procedure, the radiologist will use the venous pressure transducer to track changes with the hepatic vein pressure gradient. The first step of a TIPS procedure involves cannulating the right internal jugular vein with a large guiding catheter. The second step involves threading the catheter down the inferior vena cava to the liver's hepatic veins. In the third step, the hepatic vein pressure gradient is checked, and contrast dye is injected to distinguish the portal vein and its branches. In the fourth step, using the needle at the end of the catheter, access is obtained from the hepatic vein through the liver parenchyma into the portal vein. The fifth step involves a pigtail catheter being passed over the initial catheter to widen the pathway created in order to make room for the stent soon to be placed. The sixth step involves a stent being passed along the catheter into the pathway created. The seventh step involves confirming the appropriate position of the stent via fluoroscopy. If confirmation is obtained, the stent is expanded in place to maintain the patency and flow between the portal venous system and the hepatic venous system. It is during this step of the procedure that Oliver should ensure adequate analgesia is on board to blunt the nociceptive stimuli associated with balloon dilation. In the 8th step, pressures are obtained by the radiologist to confirm improved portal vein pressures. Benefits associated with the TIPS procedure include its minimally invasive application, as a surgical incision is not required. This is because access is obtained using the internal jugular vein. However, this method of access does come with some risks. Vascular puncture, tracheal puncture, pneumothorax, hemothorax, and brachial plexus injury can occur while threading the catheter towards the hepatic vein. Major complications are rare, but include stent occlusion, abdominal bleeding, hepatic artery laceration, stent infections, and radiation injury to the skin. Luckily, Mr. Smith did not experience any of these complications during his procedure, but late complications can occur, which include stent occlusion, thrombosis, or dislodgement. Therefore, Mr. Smith will require follow-up ultrasound imaging to ensure stent patency and flow remain optimal. The goal of the TIPS procedure is to reduce the hepatic vein pressure gradient to near normal levels. Mr. Smith's initial hepatic vein pressure gradient was 14. However, after placement of the portosystemic shunt, his pressure gradient has declined to 6. It looks like the procedure was a success. So to wrap things up, reversal of cisatracurium should be performed, despite its metabolism by Hoffman elimination. Oliver will provide neostigmine, 4.5 milligrams, using the 50 mics per kilogram calculation, and glycopyrrolate, 0.9 milligrams, using the 10 mic per kilogram calculation, to provide adequate reversal of neuromuscular blockade. Mr. Smith maintained adequate oxygenation and did not experience any ventilatory compromise during his procedure. Therefore, Oliver decides to perform an awake extubation for Mr. Smith. Propofol and remifentanil infusions are turned off. Mr. Smith is able to open his eyes, follow commands, and breathe on his own. After Oliver suctions the pharynx and provides 100% FiO2, Mr. Smith is extubated.
You're okay. Give you some antiemetics, help you go
Did surgery go well?
Mr. Smith will be transferred to the ICU for closer hemodynamic monitoring, fluid and electrolyte management, and correction of coagulopathy. However, he's expected to have a normal recovery and will be able to resume normal activities after 10 days.
For postoperative considerations, this patient will recover and wake up in the PACU before being moved to the ICU. Some things to monitor for are post-op nausea and vomiting, heart failure, hepatic encephalopathy, hemorrhage, septicemia, hepatic or renal failure, and stent abnormality or dysfunction. Perioperative nutritional supplementation may reduce the short-term complications. There is an association between nutritional state and post-surgical outcomes in liver patients, and perioperative nutritional support leads to better outcomes. A pre-op nutritional consultation is of paramount importance to optimize the nutritional status of the patient, and nutritional supplementation should be continued in the post-op period. Trace elements and vitamins such as zinc, magnesium, copper, folate, and vitamin B12 are also noted to be low in patients with cirrhosis. These deficiencies should be corrected as they delay wound healing and increase the risk of infection. Pain management in patients with cirrhosis is a unique challenge. The dose and frequency of opiates should be reduced in patients with cirrhosis due to increased half-life and bioavailability. These patients should be carefully monitored for signs of sedation and encephalopathy, and opioid-induced constipation should be avoided with the use of laxatives. Fentanyl or hydromorphone are the opioids of choice if absolutely necessary. Although they are heavily protein-bound and as such require reduced dosing in patients with cirrhosis, the metabolism of these agents do not yield toxic metabolites and therefore may be better tolerated. These patients shouldn't be in much pain post-op, so hopefully they will not require opioids. The use of acetaminophen is not contraindicated, but it should be used with caution. The recommended dose by the FDA is 2 to 3 grams per day in the short-term period.
Mr. Smith had a successful recovery after his procedure and was transferred from the hospital in 3 days. Mr. Smith has attended his follow-up appointments, which show no complications with portosystemic shunt patency. It has been 6 months since Mr. Smith's TIPS procedure. He has remained sober and compliant with taking his medications. He diligently attends his AA meetings and exercises regularly. But more importantly, Mr. Smith is starting to mend the relationship with his daughter. Let's take a look and see how things are going with Mr. Smith.
Whoa!
How's it going?
Wow, it's been what, 6 months?
Has it been that long already?
Yeah, things are going well, but
I mean, you look amazing.
wow. Well, thank you. I've been working out and attending my AA meetings, and great news, my daughter's coming over for dinner tonight with her fiance, and I'll be able to just have a good time with them. So she's back in my life, so it's great.
That's so great to hear.
Yeah,
You take care of it.
yeah, it was good to see you.
Maintaining the stability of a cirrhosis patient, despite their comorbidities, is one of the critical responsibilities of a CRNA. An anesthesia care provider must be ready to treat patients with cirrhosis as they pose a risk for bleeding, hypoglycemia, pharmacokinetic alterations of anesthesia drugs, hemodynamic instability, and potential pulmonary and renal dysfunction. This concludes our case study, and here are our references.